Good morning, dear professors and colleagues. I will present Chandelier-Assisted versus standard. I will present our study, Chandelier-Assisted versus standard Scleral buckling for primary Rhegmatogenous retinal detachment. All us know the Scleral buckling is a highly successful technique for repair of Rhegmatogenous retinal detachment. It is indicated mainly in young patients with attached thyroid, retinal dialysis, phakic eyes with inferior detachment. However, the art of scleral buckling has declined due to the advancement in the vitrectomy surgery, the difficulty in trainee observation of intraoperative indirect ophthalmoscopy. So our work aims to compare the anatomical and functional and the rate of, functional outcomes, the rate of complications of these two scleral buckling techniques in phakic eyes with Rhegmatogenous retinal detachment, a standard technique with using the indirect ophthalmoscopy versus a chandelier-assisted technique using a chandelier light probe together with a non-contact wide-angle viewing system. It was a prospective single-center comparative randomized interventional study conducted at our hospital. All patients were phakic patients with pre-equatorial retinal breaks and or retinal dialysis with PVR up to grade C1, ZP1. The excluded patients are pseudophakic patients, aphakic patients, posterior breaks or giant breaks, macular holes, media opacity hindering visualization, previous surgeries or ocular trauma, previous other ocular pathologies, glaucomatous patients on anti-glaucoma medications. The patients were randomized by simple randomization into standard group and the chandelier-assisted group. The standard technique was done as usual. The retinopexy was done using the diopexy, the transscleral diode laser, rather than the cryopexy. The chandelier-assisted technique was done similarly to the standard technique, except that we use the microscope, except that we use a non-contact wide view system of the ReSight system, along with the chandelier light source, which was a 25 gauge light probe of Alcon. It was inserted 4 mm behind the limbus, about 90 to 180 degrees away from the primary brain. Can skip this. The patients, post-operatively, the patients were examined on day 1, week 1, 1 month, 3 and 6 months post-operatively. Spectral domain OCT was done for all eyes pre and post-operatively as follow-up visits to evaluate the vitreoretinal interface, to stage the epimacular membranes, and it was done according to the study published by Gonzalez et al. As we can see, stage 1 is an epiretinal membrane with foveal preservation. Stage 2, epiretinal membrane with loss of the foveal depression. Stage 3 is an epiretinal membrane with loss of the foveal depression, and there is an ectopic inner foveal layer, as we can see, and it is anatomically identified here in this photo. We can see the inner prexiform layer and the inner nuclear layer are migrating through the fovea and are completely and can be anatomically clearly identified. Stage 4, there is ectopic inner foveal layer with loss of the identification. Ultrasonic biomicroscopic evaluation also was done post-operatively at the sclerotomy site, and it was the patterns. There were 3 patterns according to Tusi et al. P0 means vitreous not visible or vitreous strand barrel but distant to the sclerotomy site. P1 is vitreous strand barrel and in contact with the sclerotomy site. P2 vitreous strand entrapped in the sclerotomy site, and we will see later. The outcomes was first is the primary outcomes, the primary success, which is defined as a total number of eyes with successful retinal reattachment after the primary scleral buckling surgery with or without complications. The final anatomical success, which is defined as total number of eyes with successful reattachment at 6 months, irrespective of the number and type of the interventions. Secondary outcomes, comparison between both groups regarding surgical operating time, number of reoperations, complications including mainly lens status, cataract development or progression, UBM vitreous weak grading, number of eyes with epimacular membranes detected clinically and on OCT. We have 50 eyes of 49 patients who were included in our study. The standard group included 27 eyes. The chandelier-assisted group included 23 eyes. There was no significant differences regarding the baseline features, age of the patient, sex of the patients, duration of retinal detachment, macular status, number of breaks, type of breaks, location of breaks, number of detached quadrants, BVR grading, lens status, IOP, baseline corrected distance visual acuity, axial length, and refractive error of the fellow eye. All surgeries were done by the same surgeon. There was no significant difference between the 2 groups regarding the mean surgical operating time. Regarding the operative data also, there was a significant difference regarding the intraoperative complications between both groups, with the Chandelier-Assisted group showing more complications in 14 eyes compared to 3 eyes only in the standard group. Also, the incidence of all of these, most of the eyes in the Chandelier-Assisted group showed intraoperative vitreous prolapse. We have 11 eyes of the 23 eyes with vitreous prolapse at the sclerotomy site intraoperatively. 5 of those 11 eyes developed with a significant intraoperative vitreous prolapse requiring suturing of the sclerotomy site, and the other 6 eyes did not require suturing. Regarding the post-operative outcomes, there was no statistical difference regarding the visual gain, primary and final anatomical success. Secondary interventions also, there was no significant difference, but the difference was mainly in the post-operative complications between both groups. We had only one patient showing cataract progression or cataract development and then progression in the standard group, versus 8 eyes with complications in the Chandelier-Assisted group, mainly with epimacular membrane development. In the standard group, this is one eye only, representing 3.8%, developed the cataract at the first post-operative day, which progressed gradually to posterior subcapsular cataract in the follow-up. As we can see here, the photo on the left side is taken at 3 months, and on the right side at 6 months. But this visual acuity was stable, and it did not require removal of the lens. In the Chandelier-Assisted group, we had 8 eyes representing 34.8% with complication. 4 eyes representing 22% developed post-operative macular pucker, which is a stage 4 epiretinal membrane with vectoral domain OCT. Those 4 eyes required Bart's planar vitrectomy with eyelid peeling. Another 4 eyes represent 22% developed epimacular membranes detected only on OCT, but not seen clinically, and showed stable visual acuity, thus did not require further intervention. Those eyes was stage 1 epimacular membranes. As we can see, this is one of the eyes that developed macular pucker. On the left side, this is a photo taken during the Chandelier-Assisted technique with the break seen infranasally treated by the transscleral diode laser retinopexy. On the right side, this is the post-operative picture taken, intraoperative picture taken with the macular pucker during Bart's planar vitrectomy. This is the eye with the epimacular membrane progression. A represents the pre-operative OCT picture. B represents the first month with stage 4 epimacular membrane. As we can see, there is an ectopic inner foveal layer with no identification of the anatomy, and it progressed. The visual acuity decreased until it reaches 0.05, and vitrectomy was done. In the standard group, we found 4 eyes with epimacular membranes, but it was present already pre-operatively, and these membranes did not progress. The visual acuity was stable, and thus those eyes did not require further intervention. This one of these eyes, pre-operatively, there is an epimacular membrane stage 1. There is a PCD. There is same membrane is still there with a stable visual acuity. As we can see, there is preservation of the foveal contour with no ectopic inner foveal layer or loss of the foveal depression. When we come to analyze the epiretinal membrane development in relation to suturing the sclerotomy site, we found that 8 eyes developed epiretinal membrane among 15 eyes in which the sclerotomy was not sutured. 8 out of 15, where the sclerotomy were not sutured, developed epiretinal membrane. No eyes developed epiretinal membrane in the 4 eyes in which the sclerotomy was sutured. This showed a statistically significant difference. In addition, 6 eyes that showed mild vitreous prolapse and were managed with just vitrectomy at the surface of the sclerotomy with no suturing. 4 patients developed epiretinal membrane, in contrast to patients who were sutured, and no one of them developed epiretinal membrane. This signifies the importance of suturing the sclerotomy site even if there is no vitreous prolapse, because suturing, we found that suturing protects against the vitreous incarceration later on in the sclerotomy. Regarding the ultrasonic biomicroscopic findings, we found that 12 eyes had vitreous entrapment. 12 eyes out of the 23 eyes had vitreous entrapment P2. 1 eye had vitreous membrane P1 parallel and in contact with the sclerotomy site P1, and 3 eyes had vitreous floaters B0 pattern. As we can see on the left side, there is a vitreous strand entrapped in the sclerotomy site representing P2, and on the right side there is a vitreous membrane in contact parallel and in contact with the sclerotomy site representing P1 pattern. Also, we found a relation between ultrasonic biomicroscopic findings, vitreous prolapse, and suturing of the sclerotomy site. We found clinically 11 of the 23 eyes in the Chandelier-assisted group developed intraoperative vitreous prolapse, while the other 12 did not develop, as we said before. 5 of the 11 eyes that developed intraoperative vitreous prolapse and 7 out of the 12 eyes that did not develop intraoperative vitreous prolapse showed vitreous entrapment. So we have 7 out of 12, 7 eyes out of the 12 that did not show intraoperative vitreous prolapse showed vitreous entrapment on the UBM. So the non-occurrence of intraoperative vitreous prolapse does not mean that the vitreous is not going to entrap in the sclerotomy site. To the best of our knowledge, our study was the first prospective study comparing both techniques. There were 4 studies previously published, and all of them are retrospective studies. As we can see, Tomita et al., Lee et al., Nairanan et al., Cohen et al., all of these are prospective studies. Only one study exceeded our patients with 94 eyes. Most of the studies were phakic patients. Most of the studies did not mention the degree of BVR included. Here we come to all of the studies did cryopexy, we did diopexy. Regarding surgical operating time, all of the studies mentioned that the Chandelier-assisted group has significantly shorter time than the standard group. And we found that it is shorter, but is not statistically significant. We postulated that during examination of the peripheral retina, in the Chandelier-assisted technique, it takes some time because controlling the eye using the sutures, controlling the muscles is not easy like controlling the eye using instruments while inserted inside the sclerotomist. So it takes some time also, and this may explain why the time is not significantly shorter than the standard group. Regarding the epimacular membrane, which is the most important point in our study, previously reported an incidence of 3 to 8.5% after, and it was reported after the standard scleral buckling surgery using cryotherapy or diathermy, and it was based on clinical diagnosis, mainly gas classification, which includes cellophane maculopathy grade 0, wrinkled cellophane maculopathy grade 1, and macular pucker grade 2. In our study, we used the transscleral diode laser retropexy, reporting an incidence of 22% of clinically detected macular pucker and an incidence of 44% of epimacular membranes detected on spectral domain OCT after Chandelier, because there is another 4 eyes that develop epimacular membrane detected only on OCT. Reporting other comparative studies, Tomita et al. Reported 1 eye after Chandelier, Lee et al. Detected 1 eye after standard, Tayab et al. Detected 1 eye after Chandelier, Nusser et al. Detected 1 eye after Chandelier-assisted group. Epimacular membrane, in our opinion, the use of Chandelier light can be considered the main contributing factor in the pathogenesis of post-operative epimacular membrane progression and macular pucker development. In those 4 eyes of Chandelier-assisted group, insertion of the Chandelier light converts the scleral buckling into an intraoperative ocular surgery and lead to direct entry of conjunctival and or other epithelial cells into the vitreous cavity. Also, vitreous which becomes incarcerated or entrapped the sclerotomy site can also act as a bridge of other cells to enter the vitreous cavity and proliferate to enhance the development and progression of epimacular membranes. Moreover, the insertion of Chandelier light can lead to posterior vitreous detachment, which according to Tanom et al. And Yorima et al. Can facilitate the development of macular pucker. To sum up, analysis of our data showed similar anatomical outcomes, functional outcomes, and surgical time with no significant difference between both techniques. Chandelier-assisted technique showed a statistically significant increase in the rate of epimacular membrane formation and macular pucker development post-scleral buckling surgery. So we conclude that Chandelier-assisted scleral buckling technique in the management of phakic rhegmatogenous retinal detachment neither improved the anatomical success rate nor the surgical operating time. Converted the scleral buckling surgery into an intraocular surgery with increased rate of complications, particularly the rate of epimacular membrane formation, increase the costs of standard scleral buckling surgery. Thus, surgeons should rethink before adopting these techniques in their practice. And thank you.
Thank you very much, Dr. Mahmoud. Dr. Mahmoud, is there a specific situation where you decide that a Chandelier-assisted buckle is something that is imperative and you have to do it?
Congratulations for the publications in Retina. Excellent. Well, I'm not a fan of Chandelier-assisted, but anyway, like any technique needs improvement.
there is room for improvement. Chandelier-assisted is there. This is an important issue. It يعني you highlighted. I think that you need to work on it to improve the technique. وزي اي تكنيك جديد بيبقى فيه شويه flaws, and what happens is that you improve and correct these flaws, and at the end يعني intraocular surgery او phaco surgery دخلت في مشاكل كتيره جدا 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 لغايه ما وصلنا للفيكو the standard treatment now. So I think عشان كده انا مش موافق بقى. Surgeons should not rethink. No. لا. The surgeons should start improving the flaws اللي انت قلتها. واحنا عرفنا ان surgery for example will improve the incidence of complications and epiretinal membranes. So you learned a lot from that. So congratulations. I think it is a technique which is there to be there, and it will not be abolished.
Thank you very much, Dr. Mahmoud. All right.
I mean, did this technique assist you in finding new breaks or breaks you didn't find originally? Okay.
available when we're using the indirect ophthalmoscope. زمان كان عندنا الانdirect ophthalmoscope ده كنا بنقدر نشوفه، كان في حاجه اسمها teaching mirror قدام وكنا بنقف نتفرج وكنا بنقدر نشوفه. دلوقتي ده is not available. التكنيك ده the only advantage اللي انا شايف ان هي دي teaching point. بالنسبه للموديفيكيشن احنا during this study عملنا موديفيكيشن كتيره جدا عشان نمنع الترانسليشن اوف this في السكروبس. من ضمنها ان احنا كنا بنحط بلاج جوه الكانيولا عشان ما يخرجلناش فيه. مفيش ولا ستادي عملت ابدا على ان احنا نيفالويت الانكارسيشن اوف ذا فيتس. بالرغم من الموديفيكيشن اللي اتعملت فيه كتير، لكن ستيل بيبقى في فيتس بيبقى انكارسيت ان ذا سكروتم ديسبايت ان انت ما بتشوفوش بره.
بس incarceration in the vitreous، بس عشان انا عارف التايمينج. incarceration in the vitreous itself is not a problem، لان احنا لو عملنا يو بي ام في vitrectomized eyes هنلاقي بردك.
But in this case no، مش هنقدر نعمل الحكايه دي، مش هنقدر نعمل كده. اللي انا رايي ان احنا once you go inside the vitreous stem في hazard ده ممكن يجي لك برين attachment I think ان برضه ممكن يعملوا بقى.
يعني انت بتشوف you do a microscopic، انت بتشوف حاجه تحت الميكروسكوب